Good evening. I want to thank Dr. Mustafa for inviting me back again to this forum. And I'm a little bit different than the other speakers that spoke about in this entire conference. I look at things a little bit differently. I don't look at cases one patient at a time, but I look at systems of care. That being said, I'd like to go ahead and get started. In the interest of full disclosure, I have no financial relationships to disclose. And why are we talking about a multidisciplinary approach to amputation prevention? It's because there are external forces outside of medicine, payers, insurers, patients, various groups like the Leapfrog group, for example. These are all areas that are demanding these changes in medicine. Let's take the latest from CMS, its latest partnership with patients. One of the areas that they're looking at are bringing into bear the high costs of amputation in this country. The National Quality Forum, we're looking at 20 measures that have to deal with diabetes, hypertension, peripheral artery disease. And the Joint Commission, we're looking at readmissions, adding that as a core measure for patients with peripheral vascular disease, 30-day readmissions to hospitals. Those are new core measures that are coming into play. Finally, the AHRQ for many years had their preventative quality indicator 16, which has to do with prevention of amputation in diabetics. And for many years, this has been one of the areas that determine how primary care doctors got paid. I want to make some mention here about accountable care. What really is accountable care? I wrote a paper a couple of years ago with my younger brother, who's a physician as well. And we coined the term, no outcomes, no incomes. And essentially, that's what medicine is about now. If you don't show good outcomes, you're not going to get any payment for it. We heard talk a little bit earlier about doing stuff in the outpatient arena versus the hospital. Well, I could tell you this. I came from a state, which is Texas, where physicians, if they didn't like what happened in hospitals, opened their own hospitals across the street. As of December 2010, that was made illegal in the United States from the Accountable Care Act. Let's look at accountable care a little bit, the triple aims regarding amputation prevention. The three aims for accountable care essentially improve patient safety, improve clinical outcomes. We're looking for innovative techniques to decrease amputations in the United States. Improved quality. We're looking to perfect processes of care. We're looking for ways to salvage limbs so that we don't have to deal with very high cost. And finally, efficiency. We're looking to lower cost of care and the associated cost of the amputation sequelae. From a hospital administrator's goal, for amputation prevention, there are three expectations that we expect a decrease on. One is cost per case. As you know, hospitals are paid by DRGs, so they're looking for DRG savings. We're looking for decreased complications, decreased mortality. That together with decreased lengths of stay, as well as readmissions within 30 days. On the other hand, hospitals are looking for increased market share. They're looking for a reduction of duplicative high-dollar tests, and they're looking for multi-specialty collaboration for critical limb ischemia. And that's what we're going to talk about today. What's the importance of a collaborative team? Someone said that by working as a team, we can decrease the amount of amputations in the United States by 70%. And why is that? Because teamwork, as you know, improves communications among caregivers, and also allow caregivers to pool techniques to improve patient outcomes. What does a multidisciplinary team look like? Well, you can see the various members that are listed up there, and some of them are on the podium here today. People working together to produce the best outcomes for patients so that amputation become more of a last resort rather than the first line of therapy for patients with ischemic limb disease. Today we have on the panelists, as our panelists, various members that are listed. Dr. Ramai is not with us. Instead, we have another vascular surgeon up on the panel with us right now, Dr. McKenzie. So I'd like to begin as part of the panel, just to go ahead and answer these questions. We know committed contributions and a common sense of purpose does decrease amputations. Now for each of you, I'd like you to just answer very briefly, how does each specialty contribute? We heard a little bit from podiatry. And is collaboration more beneficial to each specialty than competition? I'll start on my right.
That's me?
Yeah.
Right? Okay. I'm on? Yeah. I'll say at the beginning, maybe to be a little provocative or disruptive, I think a lot of the work, the blocking and tackling that needs to be done can be done by non-physician personnel. We did a program in New York City with an insurance company called HIP, which is now defunct, but we had 10,000 people with diabetes, and we had 10 nurses going out there doing foot exams and ankle brachial index. And in 2 years, we reduced the amputations by 33%. And it was really just from the screening. And, you know, we put too much pressure on ourselves. I mean, we can delegate a lot of this work to other non-physician personnel, and we should be on the back end to handle the more complicated cases.
Dr. McKenzie?
Yeah, actually, Dr. Davis and I authored an article in Endovascular Today, which you all were given when you got here, on this and how you can work together as a multidisciplinary team. And I certainly think this is the best way to go. Everyone needs to come in and kind of check your egos at the door when you come in and really let the people that do things the best do it. And that may be different in each institution. You may have a very active podiatrist that's going to be managing the wound care. You may have a plastic surgeon. You may have an internal medicine doctor that's doing the diabetes and the wound care. So each institution, you've got to figure out who's going to do what. But then you have to kind of let them do their thing and then work together such that we as vascular surgeons may come in and say, we're going to do the bypasses, and the interventional cardiologists, interventional radiologists are the ones that are really going to do the percutaneous interventions. Or in our institution, we do the percutaneous interventions, as does the interventional cardiologist, as does the interventional radiologist. But we all compare our notes to make sure we're all giving the best possible care as we can. And then we also work with podiatrists, wound specialists. We have dedicated physician assistants, as well as discharge planners, coordinators, all that coming together as a team to try and make it work. Trying to get one person to do it all just doesn't make any sense anymore.
Very good.
Absolutely.
Well, I think as Jim has said, we you know, at our institution, we have a wound care center that really is run by the podiatrist, and then there is the whole sort of spin-off of all the other subspecialties. I think limb salvage is such a unique and specialty-driven problem that you really need dedicated people in doing what they do, and no one can do everything. And that's the whole problem. And I think you need the best available people doing each part possible. And if you're going to be successful in doing this, and as you talk about pay for performance, if you don't have the best people doing their parts, you're not going to get paid. And so I think that's why we have wound care being driven by the podiatry. We have plastics, we have general surgery there, we have vascular surgery, we have the interventional cardiologist. So we're all really driven as a team along with medicine when endocrinology is involved with the diabetes. So I think you have to have every one available because we can't all do everything and be all. So.
As an orthopedic surgeon who's also in a wound center, very, very, very important to have a collaboration between each specialty to be able to get the best care for the patient. But just don't forget one thing, the nucleus of this whole problem is also the patient. Recruit the patient, recruit their family members, recruit their psychiatrist, recruit the nutritionist, the diabetic nurse, the lymphedema nurse, the wound vac nurse. Everybody has to come together to give the best care to the patient.
Again, my concern, I think what we're saying is great, and I'd love to see the concept work wonderfully, because I know even at my institution, the wound care facility works separately than us. And I still have that point where we have this nice round table going. But it really does. That model has to be perfected. But again, I think the odd man out here is the patient. because it's the patient most of the time that I find that causes success or failure. And to have it put back on us is a tough thing. So one of the kind of things is, and I mentioned in my talk, psychiatric evaluation of these patients. Really, it's really important.
Very good. We know that timely evidence-based interventions is the key to amputation prevention. And what are the barriers to timely consultations? And did your hospital help you overcome those barriers? Again, we'll go to the right.
Well, in New York, where I practice, one of the barriers is the payers. A lot of the subspecialists do not accept insurance, so I get stuck with referring to orthopedics or vascular because they won't accept the patient based on their insurance. That's my commonest problem.
Well, we basically accept everybody's insurance, and including Medicaid, which basically reimburses at the level of what we pay our billers to submit the bills. And so, I mean, I think that really isn't an issue of getting patients in. I think the appropriate identification of the issue is probably more important for our institution, of saying how are the patients getting identified and then getting the appropriate phone calls to we have a critical limb center, and making sure those calls are not going to somebody that's dabbling or whatever the case may be. So I think the branding and the getting out the word of this is available, timely getting consultation with 9 faculty members as part of the interventional team, plus then going out to the other interventionalists, it's really not an issue of getting them in to be seen. It's just getting them so they can be identified that they need to be seen is the problem.
Very good. Again.
I have a comment to make. It's very easy to put pressure on the physicians, but there's no system to punish patients for what they do. I recently had a patient about 2 weeks ago, came from nursing home, pre-gangrenous foot, heavy smoker, and I told her, you need to quit smoking. She started crying and got mad that she enjoys smoking, she will not quit, So where does, all the rules and regulations come, when you have to, a patient need to be punished, also for what they're supposed to do when they don't do that?
Very good. My only comment to you is that always do what's right for the patient, regardless of cost, regardless of whatever. Do what's right for the patient.
Well, I had some difficulty understanding everything you said, I think, because of some feedback here. But what I was able to pick up was more, what do you do with a patient that isn't actively participating in their own health care? Yeah, they continue to smoke. I mean, we certainly see patients come in, and that was to my point also, is that they come in and they have gangrene in their foot. How long has it been that way? A month, 2 months. Why did you wait so long? I thought it was going to get better.
The U.S. is unique among nations in the world in that it's one of the few countries where people really, really don't take responsibility for their own health. I mean, we see people that are abusing drugs every single day, but what do? We go and we bomb the farmer in Colombia, or we bomb the farmer in Afghanistan, and we don't address the problem home here. And not until people start to take responsibility for their own acts, like smoking and losing weight and avoiding all the junk food and things like that, only then we can make progress in that regard.
So we're going to start bombing McDonald's and RJR?
But I've been dealing with this patient population for over 20 years, and it's particularly more acute problem for them. They're a very non-compliant group.
Yeah.
I just want to bring this back down to a patient level. What you say is true. I'm frustrated at times by the expectation that I should care more about my patient's disease than they seem to. But we really don't have to do this if we don't want to, and this is still a service business that we're in. And I don't think that it goes any further than that. We really are here just to take care of these people, and they have no obligation to change their habits for us. It's frustrating, but, and it's childish that people expect that, but it is kind of that's the ground substance that we work in.
Actually, they do. There's a finite amount of money to care for this country that because of
that this is a new way of thinking, and I certainly don't want to be argumentative, but this is not an economy we're living in, it's a society that we're living in.
You know, let's go ahead here in the interest of time. You did raise an important part. It's why CMS just announced their partnerships with patients. Hopefully, the opposite is going to be true. Patients for partnerships with practitioners. I'm going to move on to the next topic here real quickly, and I'll go to the left side of the table. The challenges of new treatment modalities does impact amputation prevention. What are the challenges you face? And rejection from lack of awareness versus embracement as evidence-based, and I'll start on my left hand, extreme left.
I'm in an institution that really is, we've gone evidence-based like most people. And I don't really find, the challenge I find mostly is education of the physician as well as the patient. Patients will basically follow what you say. That's what they're doing. They kind of put their trust in us, obviously. And I just think it's the education of symposiums like this, of all getting together, telling you what we can do as a collaborative group, because evidence-based is great, but you've got to get the word out. I think that's what we're done here today, or yesterday, as well as today.
Dr. Singh?
The challenges I face can be pretty much two words: non-compliance. I mean, again, in the Wound Healing Center, 9 out of 10 patients have been non-compliant to be where they are. They wouldn't be having a wound if they were compliant on day number 1 anyway. So it goes back to education, goes back to teaching them. We must have, I mean, like we said, yes, there is finite amount of money available, and yes, you know, all that is true. But what's the truest is, if we can hopefully educate that patient, not only for that particular generation, but for the next one, I think that we can win the battle eventually.
Well, as an interventionist, I think my challenge is on these new treatment modalities, at least in the interventional world, is that there's a rapidly changing technology, and each technology itself reinvents itself every 6 months to a year as they keep on trying to improve themselves. And we really don't have evidence-based data behind a lot of these things. Mm-hmm. So you're using things that intuitively you think are good, and it's impossible for a lot of these companies to put data out, because by the time a study is done, with all the lengthy times that we have, that technology is outdated. And so really we're really treating more based on what our intuitive or what our historical experience is with these new devices, new technologies, versus any data that we're coming from. So I think that that's a difficult aspect, especially trying to convince hospitals, convince payers that some of these things may or may not be beneficial. At least you can see it in your hands, but you don't have anything to prove it with.
Very good. I'm going to move on to the other one, and this is the final topic we're going to talk about. It's about multidisciplinary teams contributing to amputation prevention. What are the pros and cons for independent collaboration? And is there any advantage to a hospital-based team? And again, I'm going to go to the right.
Yeah, I think a hospital-based team is probably the most fiscally proper way to do this, also in a regulatory sense. And hospitals usually will support it financially because of the increased activity. I've been running hospital-based programs in New York for 20 years, and it's all worked out very well for the patient, for the hospital, and for revenue generation. So I think there's a clear advantage to the hospital-based team. As far as multidisciplinary teams, absolutely. There's a lot of evidence, a lot of papers going back to the late 80s. Michael Edmonds in England was the first that I know, but it's essential to the care of these patients that it be multidisciplinary.
I'm going to have to be a little bit more of a realist in this. I think certainly that's the ideal situation, and that's what we're trying to do in our institution. And we've worked with the hospital to get a dedicated space, a dedicated area where we can bring the specialists together to do what they do and do best. But the problem being is, let's say you go in an institution where you have an interventional cardiologist, an interventional radiologist, a vascular surgeon, an orthopedic foot and ankle specialist, an operative podiatrist, all trying to compete for that group. and they are not joined financially. How do you get them all to work together when they're actually competing among themselves? And that's really where the problem comes in for a lot of these things, is that if we were all hospital employees, that would be great. Or if there's one group and only one group that does each one of these areas, that would be fine. But what we have to face with is the reality of, when I go out and start talking about my program, I have to be careful to identify it as a vascular surgery program that then collaborates rather than a Columbia or NYP-based program, because there's other factors that come into it. So until we all become hospital employees, which I do believe it will happen sooner rather than later, and I don't think it'll be a good thing. But I think this is something that we're going to have this competition because we're all still, except for Tom, based on generating revenues procedures that we do.
Yeah, and as you know, in the state of New York, they required Joint Commission accreditation for all office-based, and that's coming throughout the rest of the country. The state of Florida just asked the Joint Commission to come in and do a complete assessment as to whether the offices in Florida need to be accredited like the offices in New York, where procedures are done. So that's what's coming next. I kind of agree with you, Dr. McKenzie, that this is a lure to get it into the doctor's office, and then eventually, as more cost-cutting acts come down and the dollars get more limited, then the offices are going to be next. And we can go ahead on the left.
Well, I think independent collaboration, I think you have to have someone running the show. And if you have a hospital-based team without a leader who's doing that, or running the wound care or limb salvage team, I think it doesn't work. Independent collaboration works when you have competition for that, and the best people and the best individuals are doing their appropriate things. So that's why I think if you have a leadership of that team or group, whether it be the vascular surgeons, podiatrists, or some other wound care specialist that's actually running the show, and they know what they need out there, whether it be ID, vascularizations, or whatever, they can make the determinations who they want, who they see best. I think that's where the independent collaboration works best.
It's basically, you're trying to score in a sport, and you need every sportsman to do their job. Not one player can win against everybody on an opposite team. So I think I come from a place where there's independent collaboration between different specialties coming together in one healing center. And really, over time, I've been in this wound healing center five and a half years now. Over time, what goes around comes around. I'm a fan of that. If I lose a couple of patients from a surgical standpoint to let's say a plastic surgeon, eventually it'll come around to what he cannot do, I would have to do, and it all, I think, in my opinion, again, goes back to do the right thing and let nature take its course from there on.
I think it's the only way we can go forward, especially with the new guidelines that are coming forward. We can't do this alone. We know we can't do it alone. And like I said, what we said out here before, it's up to changing the mind of the patient. And when the patient finds out they're going to be responsible, I think they'll get in line. What you were saying to finite amount of money, when a patient realizes they just don't have carte blanche anymore, I think they'll line up.
And just to finish up my talk a little bit, I do get to go to Washington, D.C. quite a bit. In fact, a couple of weeks ago, I was interviewing in the office of the Secretary of Health for a position in Obama's cabinet. And the long and the short of the story is that when they see physicians, we are very competitive people by nature. It's why we are and what we do every single day. But when they see physicians as not being team players, as not willing to work together, especially specialty societies, not working together, just supporting their own mission, vision, and values. And not until we as doctors do what's right for the patients by working together, once the financial incentive has been removed from it, which is what they want to do, only then I think the patient is going to benefit, and it's all going to be about the patient. So let's, what I heard here today was great things. I mean, this is the start of it. This is my colleagues up here. I feel very proud being associated in the same stage with you guys, because you do have the perspective of the patient in mind. With that, I want to thank you very much.